All right, we're getting started. I'm Sasha Nicole.
And I'm Star.
And I'm Dr. T.
This is Amerikan Therapy, the definitive podcast for all things Black mental health. And we are super excited today. We came into an emergency recording because we got a bomb guest star. What is going on today? Who?
Okay, so y'all know I online stalk, okay, right? Okay, so we got a good one. I was watching The Breakfast Club. We saw Dr. Rheeda, and I was like, oh my God, that's the book that I want to get, and it's everything. So she's going to tell us, break down why Black mental health now, and why it's not a fad.
Right. So a little bit about Dr. Rheeda Walker.
Oh, I saw that head turn. She was like, oh, it's not a fad.
A little bit about Dr. Rheeda Walker. She's a licensed psychologist and professor of psychology at the University of Houston. She has published more than 50 scientific papers on psychological risk and resilience in African American mental health. And her recently released book is The Unapologetic Guide to Black Mental Health. And so we did some digging. And first of all, we love the name, The Unapologetic Guide. Because we do need to start moving in a more unapologetic way of the things that we need within this community. And so some things that we found about the book is basically addressing the crisis in our world today and how Black people, as we know, are disproportionately, dying at high rates of chronic illness and so many other things that we're suffering from. So we just want to jump right into it. First, thank you for being here, but tell us what brought you to the book? What is it about? And, and why it's so important for us and why Black people as a whole, we need to start taking our mental health seriously.
Yeah, well, thank you so much. I'm glad to be here to have this conversation with you all. I think that for me, what happened that sounded the alarm was the suicide rates going up for Black children, age 5 to 11 years old. And I've been studying suicide since grad school, and I never imagined that we would get to a place where the rates were higher for Black children than they were for white children. But that's where we were in 2016, and the stats replicated in 2018, because I thought maybe it's a blip on the screen, but it seems like it's holding, and I was concerned that that is a signal that we already knew that we were going in the wrong direction, but that said to me that we're really going in the wrong direction, and it concerned me that no one was talking about it. I don't know if people knew, and I felt like, we need to start having some community and some collective conversations to turn this ship around.
So now, okay, you talk about suicide, and I've had people in my family that have taken their own life, but in our community, we don't talk about that. We would just be like, he was challenged, she struggled, and just keep it moving, be at the funeral acting like the person just fell asleep and died. What do we need to talk about? How do we, and what do we need to do to open that conversation up? Because suicide is a hard thing to talk about, any community.
It absolutely is. And that's why I actually give language in the book, because for me, my concern is that we hear the word suicide and we run in the opposite direction. We hear mental. It doesn't even have to be mental health. We just hear mental. We hear men, and we run in the opposite direction. So we have to start to, I think, have a shared language and start to normalize. So one of the things that I talk about is not just this notion that, people are crazy or that person, like you said, struggled, but let's talk about just the range of where people are, right? So when our minds are right, we can go to work, do our jobs right, we can function at home, we're not overwhelmed by stress. So we need to start to normalize that our well-being is this on a continuum, and there's some people on the far end of that continuum who are in considerable pain, but we can all work together to get those folks back at least towards the center so they don't get to be in a place of crisis. Does that make sense?
Mm-hmm. So I have a child who is 7, she's soon to be 8, and I was on a field trip not too long ago, well, before COVID, obviously, and there were kids on the school bus who were talking about, not necessarily, well, to a degree, not them committing suicide, but they were talking about death in general and about suicide, and all of these children were 7, 8 years old. And so I ended up saying something to the child like, we're not gonna have, that type of conversation here on the bus, but can you share, how did we get this blip on the scale? How do children, even at that age, when I was 7, I never thought about suicide. Now, as I got older, there were moments that I had where I thought about different things of that nature, but what do you think is the shift that's happening within our Black community and with our children, where these numbers are starting to become staggering? Like, what do you think is happening here?
Yeah, I think it's a lot of things, as you might imagine, and suicide is very complex. So two different people might experience the same circumstances, and one is vulnerable and the other is not. But it's something about the individual that they're able to deal with the different stressors, right? So, and I do want to give this disclaimer that I don't identify as a child psychologist. So I do want to give that disclaimer, because I want to put effort into the adults who, fortunately, you were on that bus. You know, I want to put effort into the adults so the adults can be the one to intervene, because I don't know that children understand, you know, what suicide means. You know, they play video games, and unfortunately, I think some of them think that, like, oh, you know, you might die here, but then you come back in another life, like cats or something. I'm not sure. But I do think that over time, and this is the work that I've been doing in my research, that we've always had a strong sense of who we are as people of African descent. Like, or as, if we want to say Black people, that we didn't see ourselves as necessarily part of the mainstream, and something about being who we are means that we have resilience and we can come together as a community and we can be successful. But over time, what we've been socialized to think is that if we just act like everybody else, then we can be successful in life. And so we have children, I have students in my university class saying, well, Dr. Walker, I don't know nothing about being African or Africa. I don't know anything about that. I'm just American. And so I think that to the degree that we, one, have stress and struggles that we've always had, bullying has increased, but then we have less of that protection of, like, I'm good, you know, I got this. My people have been through worse. When we have less of that access, I think, you know, and added to a myriad of other factors, that it puts us more at risk.
Yeah, I would add to that a lot of people have looked at this data since 2016 and really been perplexed. Like, there isn't one single thing about why we're finding such young Black children, and especially girls, completing suicide. So it's not just attempting, but completing suicide, which, as Dr. Rheeda said, is horrific. We don't know, and everybody has tried to figure it out, because it was such a startling reversal of all the historical data that we have. As Dr. Rheeda said, I'd like to emphasize, you guys know I talk about all the time the social fabric, right? Our sense of community, our sense of belonging. And, you know, Sasha, you said something, but there are so many parents today that don't feel comfortable anymore taking care of the community, right? Because they're afraid that somebody's mom or dad is going to say something or take it the wrong way or be offended. And so our social fabric as a nation, but particularly in the Black community, our social fabric is torn. And I think this is really a significant cause of why our children are suffering so much.
What do you think is tearing that social fabric, though? Because, like you said, resiliency, Dr. Rheeda, and that tapped to me, because that's something, like, I think we've talked on the show a lot about resiliency, and there seems to be, I don't know if it's social media, I'm older, so, you know, we always say it's social media, right? But, like, is it the video games? It's like something, I see it even in my own nieces, where things that I wouldn't even have cared about, they're like, you don't understand, I can't go to school. And I'm like, what the hell? Like, just smack the girl in the face. Like, if she roll that round, give her one too. But, like, they don't see it that way. You know, you understand what I'm saying?
Yeah, I do. Video games, social media, all of it. I mean, we know when we expose children to content before their brains are ready to receive and understand and process that content, it puts them in a risky place. I mean, we know that the brain for women doesn't develop until they're age 18. For men, it's age 25. And so when you give children adult-related content, the brain doesn't actually know what to do with that content. And so, you know, I agree, it's a lot. There are a lot of things, but I do think that we have to be more intentional about getting within community, explaining to our children things like, you know, here were some of our inventors. These were our scientists. Everybody loved, you know, learn about Katherine Johnson. We need to learn more about who we are and what we bring to the table beyond a lot of what we see and say, you know, do people still watch music videos? Like, video, and TikTok. You know, we need to be intentional about educating our community.
So shifting back to your book, The Unapologetic Guide to Black Mental Health. And one of the things that when I was looking everything up and reading some pages, and it said, navigate a mental health care system that is unequal. Mm-hmm. And so what we know to be true is that our healthcare system is unequal. Even when we talk about just general healthcare disparities, I can only imagine, like when you talk about birth equity, when you talk about, you know, this whole COVID thing and how all of a sudden it's disproportionately affecting Blacks out of nowhere. And I want to be, you know, careful with my words because I don't have that data. But what we do know to be true is that we have unequal healthcare. And so talk to us about, you know, that within your book and some things that you've suggested, things we can look out for, and how your data and your research has come together with that.
Okay, Sasha, I might need you to help me out because you have like 3 questions embedded.
I'm sorry, I just be my mind. I just
download your brain real quick for us.
but I can help with one. So you're right on with the statistics with COVID-19 that we are diagnosed more and we are dying more. And actually it didn't come out of nowhere because this has always been the case. You know, we've had more diagnoses of asthma. So when they say people with underlying conditions, we are the folks with the underlying conditions. That has always been the case. And at times it's been the case regardless of whether or not we have insurance. So we can't say it's just related to access and insurance and means, but so yes, that all is true. Now, can you help me out again with the second part?
And speak to us about how you talk about the unequal healthcare and how we can use your book as a guide to, you know, digest and get through that and use your book as a guide to being unapologetic about our mental health.
Yeah, one of the challenges, and I know this for a fact, I'm sure you all can relate to this, that we oftentimes look for therapists who look like us. So people will ask me like, hey, can you give me a recommendation for a Black therapist? And unfortunately, I don't think there's enough of us to go around. There just aren't. And so one of the things that I talk about in the book is you might have to see a white psychologist. Overwhelmingly, mental health professionals are white women, just across the board, master's level, MD, across the board. And so if that is the person that you have to see, ask some questions like, so what percentage of your patients are African-American or Nigerian-American? Like, and we know when people are uncomfortable with a question. And so if there's some discomfort, you know, okay, thank you. And you can exit stage left. But if the person is, you know, comfortable answering their question and seems like they're comfortable working with you, then we kind of have to suspend discomfort around race, because at the end of the day, we're going to the person to learn skills. There are mental health skills that are absolutely universal. In fact, I would say most skills are universal. It's just kind of how you deliver them. And so if we need to go to the person to get the skills, the most important part of mental health care is being comfortable with the provider. So ask the person who they work with, ask them what kinds of things they do in their therapy, ask them their approach to therapy. For me, I train doctoral students to think about thinking. We connect thoughts with behavior, with feelings. Mental health providers have different approaches. So ask the person what their approach is and decide whether or not it seems like a good fit. Did I do good, Sasha?
Yeah, absolutely.
We're all laughing, Dr. Rheeda, because I have been beating this drum about us getting comfortable with therapists who don't look like us, probably since I've been on this show, because of the reasons that you said. And I mean, and more and more, I also do consultations with families that are struggling and trying to figure out next steps when they're not getting what they want in the mental health care system. And I spoke to a mom yesterday who has a 9-year-old that she's adopting, and he's had trauma, and he's been seeing a Black therapist for over a year. And of course, they have some distance now because of COVID. They haven't been able to see that person, but I was giving the mom these ideas and the suggestions and questions to ask the therapist. And she said, well, in this call, you've done more than she's done in the last year. And they play Othello once a week. he likes Othello and he's really good at Othello, but they've never talked about his trauma. And I said, well, when you go in and talk to her, what did she say? Did she give you tips? And she's like, well, she's never included me in the sessions. I'm like, okay, we have to stop accepting just because a therapist's skin is brown that they're going to do right by us as well. So it's both sides of the coin. Even if you found a therapist who is Black or brown, you need to make sure they're meeting and giving you the same quality of healthcare, mental health care that you deserve as well.
How do you do that though? Because any doctor patient situation, there's like an inequity, or it feels like as a patient, because you have all the knowledge, I have all the problems. Now I'm walking in and I'm scared of the doctor. I go, but I am scared of the doctor because my mother used to always say, when you go to the doctor, all they do is find a problem. And I know I'm not the only Black person or any person. And so how do you get the courage to do that? Because you're right, you should push back, but a lot of times you may not feel comfortable, especially if you don't have any education and you were sent to this person, even sit there for a criminal matter. You may just be just sign the paper and let me go on about my business.
Yeah, so, and maybe hopefully, the book inspires people to assert themselves, because I get when you go to a professional and you don't know the questions to ask. So I 100% get that. But if a person is going because they have a problem, because I understand also, people will find problems if they go looking. That's all you go look, you find a problem. But if the person is seeking help because there is a legitimate issue and they say, this is what is going on for me, tell me your thinking about what you see as the cause of the problem. Because this is the other thing. Different providers will have different assumptions about the cause of the problem. So I assume that playing Othello, okay, I don't know what the cause of the problem is there. I was gonna try, but I cannot. But based on so a person might say the problem is in the family. So then they try to help them figure out, how to navigate family better. Or they might see the problem is internal to the person. Maybe you need some assertiveness skills. But either way, the person wants to hear from the professional, what do you see as the cause of the problem and what can we do to change that problem? I assume Othello helps. Let me just say, I assume Othello helps. Different people have different approaches, but they also need to communicate directly. We are playing Othello. We are doing this homework strategy. We are learning this skill to address this problem. And that is and I talk to my, doctoral supervisees about this. You have to let the patient know what your approach is and why you're doing what you're doing. But I do know that overwhelmingly, we hear about a lot of situations like what you're describing, Dr. T, where folks are doing things and it's like, well, it feels nice, but it doesn't address the problem.
Yeah.
So how do any other pointers that you would give in how we navigate through a system that is steeped in deep racial bias?
If you are, well, we always say, do your research first, right? Every author or every guest that we've had always tells us, and we tell our audience, do your research. Everybody doesn't have computers. Everybody's not great at looking up stuff. But even if your research is talking to your community, talking to other people, try to find out something so that you're not going in without questions of your own. Even if your question is, what should I be asking you, right? Something that gets the dialogue, because a lot of times doctors want to know that you want to know. Some people don't want to know, believe it or not. They're just like, can you get cut to the chase? So make sure you've done some research and you're going in with questions that you can kind of insist on answers to, right? And if you don't understand, ask for it to be broken down even further. And that's where I think we struggle, because if we didn't get it the first time, we're scared to ask again because there must be something wrong with us, right? Not that the person didn't communicate well with us. And so one is, yes, we have to get our courage up. Two, if we're prepared and have research, we've also talked about advocates or partners or friends or support, bringing somebody with you who has a vested interest in your health and is gonna stand up with you and for you if you start to fade away in the conversation.
I also think that we, in the short term, we may We will have to have the kind of approach to finding a provider that we have to, like when we're looking for a hairstylist or somebody to do our nails, right? So that takes time because we won't always find the person on the first try. In fact, a lot of times we won't. And so it's good to have like a list of 3, like, okay, here are 3 good people. I got this recommendation here. I found this person online. I'm going to try these 3 to see, who could be the best fit. We do this when we're trying to find other folks for other services, but when it comes to mental health, it's like, oh, that person didn't work out, and so I give up. And we have to have a different perspective. I do think that longer term, because you mentioned these deep-seated biases that exist. Long term, we have to figure out ways to get more of our own providers into these systems, to get folks into these training programs, who are invested in the community, because not all of us, all of our skin folk ain't our kinfolk. And so we need to get more people who are invested so that long term, we're not still having these same kinds of conversations about like, well, I couldn't find anybody because I had to go see somebody I was uncomfortable with. And I do wonder if racially our society is going backwards rather than forwards.
Oh, we going backwards. But like, okay, so we're getting ready for a show, Dr. Rheeda, about the criminalization of Black mental illness, right? And so can you help us understand, like, we're talking more now in society about anxiety, depression, which are serious, but they're not. We had that show last week about bipolar 2 or bipolar 1 disorder, which is like a serious mental illness. Can you help us understand how we can help our family members or ourselves that have like serious mental illnesses navigate the criminal system and even like maybe work? Because do I tell somebody I have a serious mental illness so they understand that when they're dealing with me, I may not be processing right? Like, how do we protect? You get what I'm saying, protect our folk.
I think so. And I think one of the things that comes to mind, you can help me out with this, because I think about when people who have serious problems and they're acting out. So say they're in the home, and they're fighting, they're struggling, maybe they're hearing voices and they become dangerous. Yes. And so then law enforcement is called to help. And then these individuals end up someplace that's not going to provide any care, i.e.
Yes.
jail, in the criminal system. And how can we best help those individuals?
Yes.
And so I think I understand the question, but I don't know if there's a good answer for that right now, other than finding advocates. And in some cities, there are, in the legal system, there is built-in social workers who are dispatched to help out. So we have that in Houston, where if someone is called, if the police is called, and they understand there's a mental health situation, there are trained social workers who go along with the police officer to help to, mitigate some of the stress and the struggle and the negative or adverse outcomes that could happen. I assume that's happening in other cities, but maybe not. But if there can be some advocate, and we talked about advocacy earlier, some advocate who is willing to speak up for that person. Now they're on their own, so they're out in the street and the police pick them up and there's no one with them. I don't know of a way that person can be protected. I do know that what's sad is when we are fearful of calling the police because we don't know what's worse, the person who's having a psychotic break or the police who doesn't respond to them. And I honestly, I look forward to the conversation that you'll have next.
Dr. Rheeda, can you share any other tools and just things about the book that are very important in combating the stigma of mental health in general, and just some things that you'd like to leave us with knowing, and why this book is so important, and why all of us need to read it?
Yeah, well, I have decided to just confront and dismantle the use of the word mental. Like, it's just been so disruptive for us. Like, we can't even have a conversation. Like I said, you said and people are shut down. I had a relative to say, oh my goodness, I started reading the book and I thought it was for certain people. But I think everyone should read the book. And that's why I wrote it, so that we can understand the nuances of what it means to be emotionally well. And so in the book, I introduced the term psychological fortitude, because the reality is that we actually need more than the mental health, because we're, managing racism, we're managing subtle microaggressions, which actually cognitively have more impact than overt racism. Like there is so much going on that we have to navigate, that we have to have a different level, like just a whole nother level of well-being. And so in the book, I talk a lot about just this notion of psychological fortitude, and I talk about the different threats to psychological fortitude. So being disingenuine. So as an example, people who go to the same job every day and are miserable, but still taking care of family, still running around. Maybe one of the reasons we're in COVID-19 is so people can slow down. That being aware of how all of that undermines our ability to deal with the day-to-day stuff. So I think, that's my main goal, is that we have a different kind of conversation about what it means to be psychologically or emotionally well. And in full disclosure, I did not want to put mental health in the title of the book, but the publisher said, but people won't know how to find the book if you don't put mental health in the book. And I said, well, people not looking for the book. Like, we're not looking for mental health. That's not what we're looking for. And also we have to come together, I think, collectively as a community, and recognize that there's enormous strength and talent in our community. We can't wait for other folks to come and save us. It's not going to happen.
Wow.
Dr. T, anything you want to add? And Star as well, as we know Dr. Rheeda, she's on a time schedule and we're happy to have her, but anything you want to add in just regards to how we can all just be unapologetic about, how we feel, what we're thinking, our health in general, beyond, it just being our physical health, but focusing on, our mental. So what's the word we should use, Dr. Rheeda?
Ooh, yes.
Instead of saying mental health, is there like a new word, or maybe something that we can use that doesn't create that stigma around mental?
It's a mouthful, but it's psychological fortitude.
Oh, you said it already. Psychological fortitude. That's why it passed me, because it was a big word.
But Dr. T said we're supposed to ask, even if we miss it, we gotta ask. So you got it.
And I do shorten it, PF. I'm still working on how we're going to use it. It has a number value, so 0 to 100, because again, we have ratings. If somebody's at a 70, it's like, okay, I'm managing all right. If you're at a 90, you're winning. But if you're like at a 40, whatever you're doing, you need to evaluate. And that's the thing. We need to continually reevaluate where we are. What we were doing when we were 20 years old, running around and not getting rest and doing all of that, it doesn't work when you're 50 years old. We have to reevaluate what works for our life, given our different circumstances.
I like that. I'm gonna do my two. I always got two, my wrap up. So Dr. Rheeda, first, thank you. The first one is gratitude and thankfulness that, one, you said yes. You were like, oh, I'm interested, I'm willing to do it. And gratitude for the fact that you sat and wrote the book, and that you're giving us, again, yet another tool that we can use. And your book is clearly going to be a resource for our community and for the extending the conversation beyond just the taglines, if you will. Now we get into some depth. And then the second one is the depth, right? You talked about psychological fortitude being the word. I think the internal work, it's time for the inner verse. And I think we always looking in the universe and looking outward. Now I think we're ready, and it's such a time as this to do the inner work. And so I like that psychological fortitude, because that sums up to me, like, basically, let's get busy on our own inner work. So thank you.
Well, thank you all so much for having me. Star, I appreciate the invitation. I appreciate you reaching out, and then we can make it work for today.
Yeah. I just want to remind people to spend the same amount of time. I love Dr. Rheeda's analogy, and I usually use the analogy of jeans. People will spend more time looking for a pair of jeans that they like than they will for a therapist. And so if they put that same level of energy and attention into finding a therapist that fits, that they do finding a pair of jeans that fits, we'd be a much healthier community.
And I'm just going to close out with saying, my last thing is, I love the unapologetic, just that word, because I do think that we need to start being more unapologetic with how we feel, what's going on with us, and taking that serious so that we can have just a better psychological fortitude in all areas. So I love that. Congrats on the book. We are wishing a tremendous amount of success. And again, we thank you. And we are looking forward to just continuing to read through the book and just get all of the information that we need and use this as a tool and a guide, not only for ourselves, but within our community. So thank you again. And we're happy to have had you. We really appreciate it.
Thank you. Oh, and if you love Amerikan Therapy, text us at 202-800-2355, because we love to hear from you, and we want all of our listeners to come into the fold, join the tribe. We're building a tribe.
Absolutely. Amerikan Therapy with a K. Follow us all platforms. Dr. Rheeda Walker. Go get the book, and we out.
Thank you.